Hello everyone, my name is Dr. Simone Atkinson with Get to the Point Nursing Notes, and today we are reviewing head injuries. So let's get to the point. Head injuries can be categorized into two types. The first type is an open fracture, which entails a break in the skin and includes injuries such as scalp lacerations, skull fractures, or disruptions in some part of the dura mater. On the other hand, closed fractures do not involve a break in the skin, but encompass concussions, contusions, and fractures. So a skull fracture is a break in the skull bone with or without any type of intracranial trauma. Now, depending on the force of the impact, a client can be at increased risk of developing a hematoma. Additionally, when the skull fractures, it can lead to infections as well as cranial nerve injury. But the most common type of the four fractures is a linear fracture. Because the dura remains intact, this type of fracture places a client at very low risk of infection or cerebrospinal fluid leakage. Now, comminuted and depressed skull fractures have higher risk of brain tissue damage and infection, especially if the skin and the dura is torn or damaged. Finally, basilar skull fractures occur at the base of the skull, and they typically have secondary injuries. Now, most of the basilar fractures are uncomplicated. However, cerebral spinal fluid and infection can result due to disruption in the sinuses and the middle ear bones. When assessing clients with skull fractures, specific clinical manifestations can provide clues to the location of the fracture for you. And in particular, basilar fractures may present distinctive signs such as the battle sign, which is ecchymosis or bruising over the mastoid process. Hemotympanum, or the presence of blood that's visible behind the tympanic membrane, may also be observed. And a third classic sign is raccoon eyes, which is characterized by bilateral paraorbital ecchymosis. Additionally, rhinorrhea, which is the leakage of cerebrospinal fluid through the nose, and otorrhea, the leakage of cerebrospinal fluid through the ear, these are also common indicators. So for diagnostic purposes, plain X-ray films, CAT scans, or MRI scans are typically employed. However, it is crucial to remember that with basilar skull fractures, it might be challenging to identify the fracture solely using plain X-rays. Therapeutic management and treatment depends on the type and the location of the skull fracture. Now, typically, linear skull fractures only require bed rest and observation without specific treatments. However, with comminuted and depressed skull fractures, they necessitate surgical interventions within 24 hours. Basilar skull fractures, they generally do not require surgery unless there's persistent cerebrospinal fluid drainage being observed. However, nevertheless, regular neurologic assessments should be completed to identify potential meningitis, and the nurse must also continue to observe for otorrhea and rhinorrhea. To determine if drainage from the client's ear and sinus contains glucose, a test should be conducted because only cerebrospinal fluid contains glucose, because mucus secretions do not. Now, the nurse should watch for the halo sign, which is bloody drainage, which indicates glucose-containing cerebrospinal fluid. This sign, the halo sign, can be seen as dried concentric rings on gauze or tissues. Now, maintaining cleanliness in the client's nose, their pharynx, and the external ear is essential, and sterile technique and supplies should be used whenever cleaning drainage from these areas. Clients should also be instructed not to blow their nose, cough, or inhibit sneezing, but instead sneeze through an open mouth. Also, aseptic technique must be used when changing head dressings to prevent infection. Medication therapy for clients with skull fractures may include dexamethasone to decrease the cerebral edema, as well as antibiotics if there is a risk of infection. Clients should also be informed to seek immediate medical attention if they experience drowsiness, confusion, difficulty walking, vomiting, blurred vision, slurred speech, prolonged headache, blood or clear fluid leaking from their ear or their nose, weakness in an arm or a leg, a stiff neck, or seizures. And prompt action needs to be taken in these situations. Now let's discuss intracranial hemorrhage. Now this condition involves the escape of blood into the cranium, and it's typically caused by blunt trauma. The hemorrhage may lead to a gradual or a rapid decline in the neurologic status of your client. Usually intracranial hemorrhage results from some sort of trauma or the application of some sort of shearing force or on the cerebral arteries as well as the veins. This is due to any type of acceleration and deceleration injury. And the bleeding can be categorized as either epidural, subdural, or intracranial. As a reminder, keep in mind that epidural hematoma develops between the dura and the skull, where the hematoma forms and strips the dura away from the skull. It typically occurs due to a tear in a meningeal artery, leading to rapid expansion and a quick deterioration in the client's neurologic status. In cases of epidural hematomas, clients may lose consciousness and experience a short period of lucidness, followed by rapid deterioration and exhibiting symptoms like drowsiness, coma, headache, fixed dilated pupils on the affected side, hemiparesis, hemiplegia, and even possible seizures. Now, immediate surgical intervention is necessary for this condition. Now, for subdural hematoma, remember that it forms between the two layers of meninges, the arachnoid pia and the dura, and it usually involves veins, but may also affect small arteries. So as blood accumulates, pressure is applied to the underlying brain tissue. Subdural hematomas can either be acute, developing within 48 hours after an injury, subacute, appearing 2 days to 3 weeks after a lesser injury, or chronic, developing 3 weeks to months after a minor injury or spontaneously. Now, the manifestations of subdural hematomas may develop slowly and could be mistaken for dementia in our older clients. Some common symptoms include slow thinking, confusion, drowsiness, or lethargy. And clients may also experience headaches, ipsilateral pupil dilation, and sluggishness, and possible seizures. Moving on to the intracerebral hemorrhage, it is bleeding into the brain tissue and can occur anywhere in the brain. Most often, or most commonly, it's affecting the frontal or the temporal lobes. Now, this type of hemorrhage often results from closed head injuries where there is some shearing force deep in the brain. And it can happen in situations like a motor vehicle accident where the client's head hits a windshield, or from back and forth motion causing coup and counter-coup injuries. Intracerebral hematomas can have various initial presentations depending on the injury, the location of the injury. Now, some common symptoms will include a headache, decreased level of consciousness, hemiplegia, ipsilateral pupil dilation, and in severe cases, expansion can lead to herniation. Diagnostic and laboratory tests used for all intracranial hemorrhages include CAT scans and MRIs, along with laboratory values that will help to provide some baseline client data. So these tools are needed or aid us in identifying and evaluating the extent of the hemorrhage. Clients with small hematomas may be managed conservatively, as these small hematomas can reabsorb spontaneously. However, surgical intervention is necessary for draining epidural hematomas and large subdural hematomas. In contrast, surgical outcomes are also less successful for intracerebral hematomas due to widespread tissue damage. Now, the primary goal of therapy for these clients is to provide supportive care and prevent complications. Nurses should continuously assess the client's neurologic status and keep the nose and the mouth clear of secretions, suctioning the airway if necessary. And ongoing monitoring of the client's respiratory pattern for rate, depth, and rhythm is crucial, especially if the client is not mechanically ventilated. The nurse should be prepared for oxygen administration as well as endotracheal intubation if the client develops respiratory distress. So in cases where cranial surgery is anticipated due to the client's deteriorating neurologic condition, the nurse should be ready to provide preoperative and postoperative care as appropriate. And measures to manage increased intracranial pressure should also be initiated. Now, medication management for hematomas is nonspecific. Osmotic diuretics and corticosteroids may be used to reduce intracranial pressure, and anti-epileptics can be administered to treat seizures if they occur. The overall focus is on providing comprehensive care and monitoring to support the client's recovery and to prevent further complications. Contusion is characterized by bruising of brain tissue resulting from blunt trauma or a coup or counter-coup injury. Symptoms may vary depending on the location of the injury, and the client may experience a decreasing level of consciousness. So monitoring the client's neurologic status for signs of complications is going to be essential, and the family should be educated about potential post-discharge complications to watch out for. It's important that written instructions are clear and information about signs of worsening neurologic status and increasing headaches should be provided to the family. We want to ensure prompt reporting to the healthcare provider if any concerning symptoms arise. So this proactive approach aims to optimize post-injury care and to facilitate timely medical attention if it's needed. A concussion is characterized as a mild traumatic brain injury and can cause transient loss of consciousness. So post-concussion syndrome usually follows the initial head injury, and it manifests with issues like poor concentration, memory problems, and the client may complain of headache, dizziness, and sensitivity to light, which is photophobia. And moreover, sudden changes in personality may actually also be observed. So it's important that timely recognition and management is implemented so that we can have better recovery for these patients. Nursing assessment of patients with a concussion include amnesia, headache, nausea, and an intact Glasgow Coma score of 13 to 15. Now, there are 3 levels of severity ranging from grade 1 to grade 3. A grade 1 concussion shows transient confusion with no loss of consciousness and an abnormal mental status lasting less than 15 minutes. Now, a grade 2 concussion includes transient confusion with no loss of consciousness and abnormal mental status for more than 15 minutes. And a grade 3 concussion involves the loss of consciousness for a few seconds, several minutes, or even longer. In conclusion, the treatment of a concussion is mainly supportive, and the client should be closely monitored for 24 hours, either in an emergency room or at home under supervision. Clients who experienced a loss of consciousness for more than 5 minutes or amnesia, they're usually admitted for observation to rule out other possible injuries. Now, as always, client and family education at discharge should include instructions on continuing to monitor for complications. So ensuring that the client and their family are aware of post-concussion syndrome is vital. This syndrome, like we said earlier, may involve symptoms such as headache, dizziness, fatigue, irritability, anxiety, insomnia, impaired concentration and memory, as well as sensitivity to noise and light. Any occurrence of post-concussion syndrome should be reported to the healthcare provider immediately. And this proactive approach, like we said, will help in timely evaluation and management if any complications arise after the concussion. All right, you're now armed with the knowledge to provide care for a client with a head injury. If you found this video helpful, smash that like button and subscribe to the channel. We'll see you in the next video.